Good morning, everyone. Welcome to day 2. It is a beautiful, sunny San Diego morning. Did everyone take a look at the water today? When you look out at the water and you take a deep breath, it just makes everything kind of go away. It's a wonderful thing. Well, we're so happy to have you back, and I'd like to think that this morning's talk, and really today, is about connecting the ideas that we talked about yesterday, all of the public health issues, the challenges that we face, and building a bridge to, well, what can we do about it? How can we empower ourselves? What are the tools and strategies that we can use to actually make change in our own communities? So far, we've talked a lot about the hearts and minds we're trying to help in public health, and more specifically, social marketing. We've talked a lot about communications that can help improve someone's life, because if you can communicate a message at scale, it can impact a lot of people. Equity, we've got that message loud and clear. We know that we have to tailor and target campaigns, that if we try to reach everyone, we may in fact reach no one. And we've talked about the intersectionality of health issues. In our hearts, we are all here because we want to help people. We care about our fellow humans. But we all sometimes ask ourselves the question, why is this so hard? Why can't it be easier? But what's great is that you are all here as change agents, and that is a big step forward, because you coming here means that you're curious, you have an open mind, and you already have a propensity to create change. So the first step forward, thank you for being here. The reason why it's so hard is because the systems and structures that we work within are not built around the human perspective. I mean, we feel this every day, right? We work in government, in nonprofits. There's a lot of rules. There's a lot of check boxes. There's a lot of things we have to do. And as we work with a lot of government agencies, I think a lot about, well, what are those systemic barriers? What are the things that we can do to kind of move beyond that? Why aren't these systems human-centered? I love puzzles, and I love maps. I love figuring things out. I'm an innate problem solver, which is both a blessing and a curse sometimes. But I really want to understand, what is it that makes something hard to do, and how can we actually overcome it? What are those barriers that we can remove? So everyone likes to say that COVID changed everything, but in so many ways, COVID actually just offered an accelerated and amplified view of how our systems and structures already work in practice every day. It's like pushing the fast forward button on a Netflix show. Fast forwarding your favorite show to get to the end, the track, the content, the patterns, they're already there. We just follow them faster. We don't have to stop as frequently, and we get to bypass the boring parts, and we're still on the same path forward. And so what's so fascinating is, despite the fact that COVID did blow up some of our traditional approval cycles, and it actually changed the budgeting process, which in some cases was really good for us, it gave us some lessons that we can learn from. So in retrospect, and in the context of public health and communications, the path we followed during COVID looked something like this. There was a public health crisis. Scientists sound the alarm. There were urgent health warnings. News stories, the news, it was on the news, omnipresent. Cries for funding, research. And then the wave came, the communications campaigns, community outreach. Somewhere, doubt is introduced. That word, misinformation, really blew up. It became part of our daily vernacular. What's true, what's not true? How can we sift as people through all of the information that is coming to us? And as we moved through this entire process, what happened at the very end was that the most important people, the people who needed our support the most from us, were often missed. How did that really happen? And we, as departments in health, were left figuring out, well, how do we address the public demand, right? The public demand, the drumbeat of questions, at the same time we can actually reach the people who need the most support. It kind of felt a little bit like this, not gonna lie. Anyone feel like this over the last couple years? I mean, whoo! unless we choose to forget. But you know, the last 3 years, we've been through a lot. And you know, we go down that staircase, and then we're just gonna get back up. But you know what? We have a lot of lessons that we can learn. And so even though we kind of want to forget it, I think that there's some value in like just going back and taking a look at really how this all transpired, because by understanding the systems and the structures, we can actually be the ones that change those systems and structures. And we do have some power to do that. We can't change everything, but if we make one step closer to change, we are in fact making progress. And I think in the field of public health, particularly after yesterday, for example, wow, we just saw all of the issues that we have to face right in our own faces. If we take one step forward, that is progress, and we have to give ourselves credit for that. So let's kind of go down memory lane, if we will. What's so interesting is that almost 3 years today, it was the day that changed everything. This timeline is still fresh in our mind. Now, the day that changed everything was the day that the president got on and told us, Houston, we have a problem. And this was actually my third daughter's first birthday, so I remember it well. Needless to say, I have very few pictures of her first birthday because we canceled her birthday party. But it was really interesting because that is when the conversation in our world of public health really changed. All of a sudden, in April and May of 2020, crisis communications were the real focus. And so there was a convergence of crisis communications and actually behavior change or health communications. They both happened at the same time. Between June and July, there was a proliferation of mask campaigns, right? We knew that that was an important message to get out there. There was this awkward time when HHS released a $250 million campaign to, quote, open up America, before there was really an understanding of what to do next. You know, our system was on autopilot. We kind of ask ourselves, well, how did this RFP get out anyways? And if you didn't hear about the Santa scandal, you should look it up. At one point, there was an opportunity to get Santas vaccinated first. How amazing would it be if we sent the message that as a Santa, you could get vaccinated first, and that would encourage everyone else to get vaccinated too? Really interesting. Got canceled on October 25th, 2020. But it's interesting because sometimes we have these crazy ideas. Some of the crazy ideas are good, some not so good, and we really have to filter through that. Well, scientists were fast-tracking the vaccine. Communications engine was revving up. In January of 2020, we were all scrambling to put together this infrastructure, create messaging, and make sure that we could communicate the message out there. But you know what? We weren't exactly sure what to say yet. The science wasn't there. So we'll talk a little bit later about, in that case, what could we have done? Now, in February of 2020, vaccination campaigns started, the communication campaigns themselves, but vaccines weren't even available for the majority of America. If you had a pre-existing condition, or maybe if you had been a Santa, you could get a vaccine. But otherwise, the advertising was out there, the communications was out there. There was no way to get a vaccine. It's one of those cardinal rules in advertising. Don't advertise a product before it's available. So by July of 2020, the narrative was wondering, why are certain communities not getting the vaccine? And at this point, so much of the funding was already gone. We had actually spent millions and millions of dollars at the top of that staircase, and then we realized at the bottom of that staircase, there were people that really needed our help that didn't have the right message. Specific populations, Black people, Asian communities, Hispanic, pregnant women, people with disabilities, rural populations. There was a separation between the system that we were on in terms of getting messaging out there and the people that we knew we needed to help. So the reality is that our systems and structures are set up on tracks that really don't necessarily put the human first. To change those systems and structures, we have to actively remove barriers, and we have to change the track that we're on. We have to think about this in public health every single day. Now, I have this relentless optimism that everything can always be better. So I think a lot about how things work. And yesterday, someone said, you know what? Agents of Change is like Disneyland for public health. Well, Disneyland also has a lot of rules, right? There's rules about when you can go, there's lines, there's just, I mean, they have their own procurement teams in and of themselves. But you know what Disneyland also has? They have the Genie Pass. And the Genie Pass can get you in and around those rules. And so I'm gonna give a few tips and tricks today of things that we've found out or things that we've experienced that can kind of act like that Genie Pass. So when we think about the barriers that exist, these are the 4 categories that really come to mind. Funding. Funding is both the thing that we need in order to make our campaigns work, and it can often be the biggest barrier. The organizations that we work in themselves, they are also very difficult sometimes to move, right? Anyone ever felt that before? How do I move my organization forward? Research can both be a wonderful, wonderful thing, but it's also rigid in its construct to begin with. And last but not least, campaigns. How can campaigns actually get in our way? So let's start with funding. I mean, funding is complex, right? Funding is spread out. There are millions and millions and billions, frankly, of dollars being spent on public health and the healthcare system, but somehow each and every one of us every day feels like we don't have enough. There's federal funding. It's this big box on the left-hand side. That federal funding is then divided into 50 states. That is then divided into 3,033 counties, 70% or more of which who actually don't have enough to do what they really want to do. And so it's incredibly complex, and we're not set up in a system to really figure out, well, how can I get the resources that I need? And then what we experience is that that funding is divided by behaviors. So then we overlay these behaviors on top of that. And this is kind of what we feel every day, and we're like, well, how do I even get started? Now, funding streams also start and stop when behaviors are omnipresent. And one of the things that we've kind of thought about really hard, and I'll give an example of this in a minute, is how can we make sure that we're not waiting for the funding? What can we do before the funding comes? It's kind of like the field of dreams. Like, if we build it, will it come? There's a question we've had, and we've done some work on that. But before we actually move forward, there's this thing called the RFP. What do we think about the RFP? Well, the RFP is that thing that outlines a public health approach and really what you want to accomplish. It is a necessary evil. It is the way that government money is spent. Now, this is an example of an RFP. This is exactly what they're trying to accomplish. There are 4 goals. There are 6 strategies, I think, and then there are 10 priority populations. And what's really great is if you look at those priority populations, you see all the populations we just talked about, the ones that we often miss. But the trick here is, if you look at the last 2 lines, you'll see youth and young adults. So here we are trying to reach these priority populations. We know, we instinctually realize we need to connect with them, but yet we're still going to reach everybody, right? We're going to do both. And that's really hard. So one thing that we've advised, and we've seen clients do this, and it's amazing, make friends with your procurement department. It's not the most thrilling thing, but if you can make friends and you can learn how procurement works, you can actually work with them to work the system. I was talking to someone yesterday who said, well, you know, when we're looking at media, we're not allowed to buy digital media. And I was like, that seems odd. Well, why not? Well, because the procurement law was written in 1984. And so the procurement law was written in 1984, and we're allowed to buy traditional media, which includes television, radio, print, out-of-home, and newspapers. So I am not allowed to buy anything that isn't on the list already. And in 1984, there wasn't any digital media. So a few of the hacks that she's discovered are, well, I can buy out-of-home television. Out-of-home television, as long as it has the word television in it, can work. There's also an opportunity to actually work with some of your media partners and ask them to put the word television in the buy. And all of a sudden, if it's television or video, it actually passes muster. So the other challenge that we experience is that funding really follows the crisis instead of preceding it and preventing it. So how can we work the systems and structures to get ahead? Well, I mentioned just a minute ago that we sometimes think about, well, how can we make sure that we're not waiting for something to happen, but we can actually move something forward on our own. Now, when we started seeing signs of the vaping epidemic in focus groups in 2014 and 15, like this was pretty early, we started to learn more from teens and listen intently to what they were telling us. What they were telling us was that despite the fact that there was no funding, we started integrating vaping messages into our tobacco work, into some of our state and local campaigns, because we knew that teens were looking for this information. What's the difference? What's the facts? We used science and the facts to make sure that we were communicating something really clear. And over time, we continued to learn more. It wasn't until 2016 that the FDA was able to integrate e-cigarettes into their jurisdiction. Most state and public health departments couldn't do anything about vaping, but we could see it every day. And so in 2017, when funding was still almost non-existent, the prevalence of nicotine and vaping in the United States doubled in grades 8, 10, and 12 across a 2-year span. Teens were telling us in focus groups that it was everywhere. Their friends were addicted. They were getting sick. So what were we going to do? Were we going to wait? We're going to wait for that RFP to come out? Instead, what we did was we consolidated. And in partnership with some of our incredible and brave clients, we used existing research that we've been gathering for over a period of 3 years, and we made available pre-developed science-based campaigns to any county or state through a license. And it created an opportunity for us to see what the campaign could look like instead of waiting for the funding to go request it. This cut down on creative development costs. It created a ready-made opportunity for a state or county, and even city, the city of Philadelphia did this, to launch a campaign within 6 to 8 weeks and to do something immediately about the vaping crisis. Today, this campaign is live in 14 states. And then we started hearing that it wasn't all just about the facts and the information, the prevention of vaping, but teens were addicted. They didn't know how to stop. And so at the same time we were focused on this prevention message, we created an opportunity with our partners at UCSF, Hope Lab, and created a program called Quit the Hit. This was an Instagram-based online quitting program that had real-life cessation counselors that could connect with teens on their time, wherever they were, and give them the same quality cessation support that they would experience if they went onto the quit line. The challenge was that the existing system, the quit line itself, it wasn't made for teens. There was no teen that was going to call up the quit line or even go through an enrollment process and get the help that they needed at the end of it for quitting. And so Quit the Hit became a really important part of a vaping prevention and cessation campaign that we've now been able to partner and create in multiple cities and states across the country. So this ready-made campaign approach has been really powerful in tackling systemic funding issues in other areas too. And so we introduced the concept of brands. And you see here that these are not necessarily focused on the organization that created the brands. These are focused on the brand that connects to the person that we're talking to. Down and Dirty was a rural campaign that we developed to reach teens who had a 3 times higher incidence of tobacco use than general population teens, and they were forgotten. You know, we would go and see that teens had friends, uncles, teachers, and in their back pocket, there was a ring in their back pocket. Why was there a ring in their back pocket of their jeans? Because their dip was in their pocket every single day, right? And they were not getting the message, and they didn't understand that this could actually cut their life short. And so the messaging around this was very specific to teens. It was about their family legacy. It was about freedom. It was connected to the values that they held so true. And that was how and why it was important to connect with them, and we were able to do that at scale. In 2018, we launched the People's Opioid Project because we saw that the opioid epidemic was everywhere. It was in those news headlines, just like we saw during COVID, but there was no prevention and education. All of the funding was very immediately going to that point of crisis. So here we had people addicted to opioids, and they were wondering, with a substance misuse disorder, well, where do I go for help? How do I prevent it? If I go back to the doctor is the one that gave this to me to begin with. And so the People's Opioid Project really focused on messaging that didn't exist. And when we started talking to health departments about it, originally they were like, I don't think I could ever get funding for this. This sounds really hard. No one in my organization or my department or my legislative body would approve this. But after we went and actually created the ads that showed alternative pain methodologies, the information about how you can become addicted in 5 days or less, and actually when we had that product, it was much easier for organizations to say yes, because it was very, very tangible. And so that was an opportunity to address a crisis that now brings us to the fentanyl effect. And we're now launching a ready-made campaign program for fentanyl specifically, because teens simply aren't getting the information, and there are a number of very tailored and targeted approaches that we need to take in terms of getting the message around fentanyl to the right people with the right message to ensure that they understand that this is, in fact, about them. So one other thing I mentioned is that we think about the brand instead of just the organization. Focusing on the organization who did the work devalues the person getting the message. It should be about them, not us. But the reality is that the person who needs to see that message isn't going to care who ran the ad. Even though we're centered around the organizations that we work for, that person doesn't care. Brands are tricky though, aren't they? Because we see them every day. From a consumer standpoint, a brand in the commercial marketing world is so much more than a name, right? It's not just the logo. It's not just the slogan. It's not just the jingle. And it's not just the spokesperson. Hey, Flo. It's an asset that actually has real value. In corporate America, the brand and the brand value is put on the balance sheet. It is money. But in public health, we often create a brand for every program or a topic. Here, this is really all about healthy eating. We as professionals are centered around the organization that we work for or who funded the effort. Organizations, though, often get in the way of the problem. It's simply the way we're structured. I mean, the funder should get credit, right? The organization's logo should be front and center, right? With all the acronyms that we all know, public health acronyms. Our consumers, our people, the people that we want to reach, they're not going to understand those acronyms. And oh, by the way, there is a family, like Maria, at the bottom of this pyramid. And the challenge is that when we create a brand for every program, Maria then is forced to figure out, well, how does this relate to me? And in many cases, what happens is that they just tune out. So part of creating a brand and part of working the system is that active listening that we talked about. Let's take a listen from the moms who we're trying to reach through brands like this.
When you have a child, you don't think as, the other responsibilities that come along. Daycare, food,
bills, rent, food, especially when her father's not involved in her life at all. So,
yesterday I worked 8:30 in the morning to 8:30 at night. When I'm leaving, he's getting up. When I get home, he's going to sleep.
I will go get fast food, which is not very healthy, but
I try and limit the fast food, and on the flip side, it is just me at home, and there are days where it's like, okay, I'm tired, I'm done.
It's hard, especially if you're not healthy yourself. To raise a healthy child is definitely probably the most difficult thing you'll ever do in your life, because it's just not gonna happen.
I work full-time, and I go to school, and I'm a mom, so I don't have like 2 hours to prep up a meal,
Just like those commercials that are, showing you how easy it is to eat healthy and everything, but I don't have the time to cut up all the vegetables and to steam all the vegetables and, and then to have to force him to eat it, and if he doesn't, it's wasted.
So we have a very clear intent when we're trying to reach moms, but this is our competition. It's so much easier to go through that drive-through, huh? So we need to be thinking about a human-centric branding approach. What if we put the humans at the center of our brand instead of the organizations themselves, and we created a unified message for each specific audience? This is gonna make your head spin, but think about this. What if those rural Latino families, instead of creating a brand about the organization, we created a brand about them? And so we talked to them about cooking, shopping, school lunches, water, home gardens. And then if we were actually talking to a group of seniors, the messaging and the brand would change. We would still maybe talk to them about cooking and shopping, but the recipes might be different. It might be an at-home setting. We could talk to them about senior exercise. And if we were thinking about new moms, we would include breastfeeding advice, how to pack school lunches, and the brand all of a sudden becomes about them and not us as an organization. We can get out of our own way. So we talked a little bit about funding and organizations. Let's talk a little bit now about research and the campaigns themselves. So we approach research sometimes with this idea that we'll confirm this through research, right? We'll just check that box. What we really mean when we say that is, well, we'll make sure that the research tells us this, right? And so in order to think differently about that system of research, instead of thinking about the research being something we have to do before we move forward and do the cool stuff and make a campaign, let's open up that definition of research and really redefine what that looks like. Let's start instead with focus group recruitment and instead think about in-depth interviews. Let's talk about in-home interviews, group-level assessments, asynchronous discussion boards where anonymous feedback can be given, or photos. Photos can actually provide an enormous amount of value when sometimes people can't put things into words. This was a focus group that we did where we recruited adults aged 21 to 29 who are HIV positive. The goal was to connect HIV positive individuals to health services. The question was, do you feel that there are any specific programs or services that you don't have access to that you would like to improve your health? And the feedback we got was everything but access to HIV services. Rental assistance, food assistance, mental health services, and childcare. And so what that means is that there's an opportunity to think about cross-cutting collaboration and for our audience to guide us towards cross-cutting collaboration. When we don't have enough funding, how can we instead go find that partner who we can connect with? We'll create the campaigns, you provide the in-person cross-cutting communications, and together we'll marry our services. So there's a question there about economies of scale. Can we, in fact, create economies of scale? How do we avoid reinventing the wheel over and over again? Now, I'm going to go back to this mask example because in the span of, I don't know, a couple months, there were hundreds and hundreds of mask campaigns. What was so interesting is that this was a pretty simple message. If you turned on the news, what would you hear? Wear a mask. And we were all, of course, with good intent, creating mask campaigns. But what if, instead of creating another mask campaign that told someone to wear a mask, we started with the research and we said, you're pregnant, we know you have concerns, what are the questions you have? You know, you're part of an Asian community and there is a barrier from a language perspective. How can we get your family involved? How do we make sure this is a multi-generational conversation? If we were able to consider that instead of all of us doing the same thing, we could divide and conquer, we could make sure that that mass campaign was out there. At the same time, we had other folks focusing from the very, very beginning on the most important audiences that we knew would need help. One thing we realized is that while the world was chasing COVID, the people were left behind to deal with those issues. And so we actually didn't do any mass campaigns. We did not get involved in the COVID crisis in a big way. But instead what we did was we integrated COVID messaging into everything else that we did. And so we did no mass campaigns, but we did COVID campaigns that were focused on vaping, nutrition assistance, substance misuse, binge drinking, mental health, because in every research project that we did, it was obviously coming up. And so here's an ad that combines the two, vaping and COVID. Take a look.
We're surrounded by viruses. If you're young and healthy, most don't pose a threat. But if you vape, you could be breaking down your body's ability to defend itself. The chemicals in vapor, like propylene glycol, glycerol, and metal particles, damage your lungs on a cellular level. And that damage in here leaves you at risk to the viruses out there. Get the sick truth about vaping at behindthehaze.com.
So we were able to get this ad out in July of 2020, which was very quick, right? And if you notice there, it's kind of like a Super Bowl ad. We didn't say the word COVID, but everyone knew what we meant. And here's another one, mental health. Let's take a look at this.
Hey Juan, how are you?
Worried. My kids are still upset about everything they missed last year. I wish I could fix it. I can't say that. Fine. You?
I'd say fine, but I read on the Up to Us site that it's better to speak up than pretend I'm okay. My wife was furloughed. We're behind half our bills. Checking in on your mental health is as essential as the work you do. Visit uptosd.org to learn more.
So mental health and COVID. Now, I'm a mom of 3. I know what the word "I'm fine" means. Anyone feel me? But it's so important because what we were able to do is connect two intersectional issues. It wasn't saying the word COVID again, but everyone knew what we meant. And so this multidimensional communications is really important, and it's an opportunity for us to work the system. So if we're going to make progress, I want to make this real point really clear. If we're going to make progress in mental health needs to be a layer of conversation in every single one of our campaigns, across every issue. We're hearing it, all of us, all the time. So think about how can you, in fact, integrate mental health into your work. So to change systems and structures, we must actively remove the barriers, and we need to think about the steps that we take. How can we take different steps? Here's 4 things I want you to take away, the genie pass to Disneyland, if you will. Number 1, get to know procurement and think critically about how to write that RFP. And in some ways, sometimes you can actually find flexibility and a new way to think about those rules. Number 2, determine how to center your audience instead of your organization. 3, expand your definition of listening and let the audience lead you to a new set of partnerships. And 4, create multidimensional campaigns that address connected topics. And with that, we will be able to accomplish a human-centered funding, human-centered organizations, human-centered research, campaigns, and a more human-centered public health. Thank you so much.